नई क्लास स्टार्ट होना थोड़ा सा लैग रहता है स्टार्ट होने में. Good evening, everyone. Good evening, everyone. So I welcome you all to Unacademy once again with this new innovative pattern of teaching. So today the topic of discussion is the CA stomach. So let me introduce to myself. I'm Dr Saurabh Dixit and a faculty for surgery at Unacademy. So let us just start with this session. So before that, let me tell you about some special programs that we have already started. You can avail them and you can use the code Dr Dixit to get some extra privilege. And I hope you know about the iconic subscription where you get the prep ladder and Unacademy, that too at a very competitive price, and a lot of features. Yeah, a special mention to the question bank, and question bank is really very awesome, you can say, and it's going to be a game changing event in your preparation. We have a lot of new batches which have already started and which are about to start. So let us start the today's topic, that is CA stomach. Now when we talk about the cancer of the stomach, it's a very important topic for exams, for your MCQs, everywhere this topic is important. So I'm not going to take this topic in a very, you can say, lengthy session. It's going to be very crisp, small, and I'm going to concentrate basically on the management pattern of the CA stomach. So let us kickstart this topic. Now, when we talk about the concept of CA stomach, now what is very important about CA stomach is to know where in the stomach the cancer happens. Yeah, and what are the types of cancers, what are the risk factors, everything we are going to discuss. Now, if you talk about the cancer of the stomach, yeah, it can happen at many places, and the most common site that we have, the most common site that we have is the cardia. Now this area, this is the proximal stomach and this is the cardia. You should know that majority of the cancers today are a cardia type cancer. Approximately more than 55% of the cancers are the cardia type. If you talk about the other cancers, we have the antrum also. Now, if you talk about this portion, this is where the antrum is, and antrum accounts for roughly 35% of the cancers. Do you know that cardia is the most common site in the West? It is the most common site in the West, and in developing countries where the incidence of H. pylori infection is very high. You know H. pylori. Yeah. So where the infection with H. pylori is high, there we have the antrum being the most common site. So we have antrum, we have cardia, and then the third one is the body. So when we talk about the body, it corresponds to roughly 15% of the cancers. So we have cardia, we have body, we have antrum, and these are the three main important things. One more thing, if you get the question, overall the most common site, the answer will be your cardia. And this is how we are starting. The most common type. What is the most common type? Answer is, the most common type we have is adenosine. Okay. let us talk something about the presentation. Yeah, let us talk about this thing. So risk factor and the presentation. Now, before that, yeah, these are the risk factors that we have. So I'll just move this image. For you. Okay. Now, when we talk about the risk factors, the one very important is the nutritional. These are the nutritional risk factors. Always remember the fruit, the salted, the smoked food. This is responsible. So smoked, salted food. So smoked and salted food. This is very important. Or you can say pickled. Students, this is also the same risk. For the esophageal cancers. So you can see low fat and protein consumption, salted meat or fish, high nitrate consumption and high complex carbohydrate consumption. They are all very important things. Now when we talk about the environmental factors, let us discuss about the environmental factors. Now these are again very important. What are the environmental factors? The smoking, alcohol. You can say lack of refrigeration. Do you know after refrigeration came into the market, the incidence of pickling went down, and therefore this is actually going to be protective now. So low socioeconomic class, they have a higher risk of infection They have higher risk of infection. Now, what else is important? Try to understand this. Okay. Now, the prior gastric surgery. Now, what is this concept of prior gastric surgery? Students, if you have done a gastrectomy, suppose you have done a gastrectomy, and after gastrectomy, you have done a gastrojejunostomy. So, more than 10 years old gastrojejunostomy status, GJ status. So, if it is more than 10 years old gastrojejunostomy status, this is again going to increase the risk of stromal cancer. So there is increased risk of stromal site cancer. So stromal site cancer is increased because of this, and this is very important. Again, H. pylori infection, gastric atrophy and gastritis. When we talk about gastritis, students, again you have to understand that gastritis, what type? Type A gastritis. Type A gastritis is responsible for malignancy. Again, remember, so I'll write there. So when we talk about the gastritis, you know there are a lot of types of gastritis. We have type A. Type A is the autoimmune type. It is the autoimmune type of gastritis. And this is actually responsible for what? Malignancy, point number 1. The second is, you must have heard of CAG. What is CAG? This is chronic atrophic gastritis. CAG is again responsible for. So chronic atrophic gastritis. And what type of CAG? CAG also we have a lot of types. We have the complete type. The complete type is more important. So complete type. So CAG, what type of CAG? This is the complete CAG. What else? Students, HNPCC. What else? FAT. What else is responsible? BRCA. So these are very important. One more risk factor when we talk about is about the polyps. Now, what type of polyp? What polyp is responsible for this? Do you know that there are two categories of polyps? When we talk about gastric polyps, we can have two categories of polyps. What are they? We have the neoplastic and we have the non-neoplastic. What category polyps are responsible here, students? We have the polyps adenomatous polyp. So adenomatous polyp, and we have fundic polyp. So adenomatous polyp and fundic polyps are the polyps which are actually responsible for malignancy. So we have seen the polyps, we have seen the gastritis, we have seen HMPCC, we have seen FAP, we have seen BRCA. Let us try to understand more important things. When we talk about the presentation, so I will go to the presentation. I'll go to the presentation. Okay. Now this is what we are going to discuss. Now, do you know that CA stomach is the only condition where the non-specific presentations are actually more important? Why? Because this kind of malignancy is associated with the diffuse kind of profile. Yes, and diffuse kind of cancers, they will not present to you with a mass related features, early features. So the classical presentation is, so there is early non-specific presentation, and what is the non-specific presentation? Weight loss, anemia, early satiety. So weight loss, anemia, early satiety, they are classical features. What are very specific features that we all have to understand? Dyspepsia. So dyspepsia, the patient presents to you with hematemesis, melena. What is difference between hematemesis and melena? Hematemesis is defined as emesis of blood, so vomiting of blood. What is melena? Melena is a term which is reserved for, so when we talk about melena, the term melena is reserved for black tarry stools. You know, only black stools, only by saying black stools doesn't mean that you are dealing with a patient of melena. Melena means black, tarry, foul smelling stools. So this is tar or pitch-like consistency, that coal tar-like consistency, because black stools can be seen even in case of iron deficiency patients who are on iron supplementation, because iron supplementation gives you the typical black stools, but they are well-formed stools, and that is why in order to differentiate a blood loss related black stools versus the iron supplementation stools, we are going to go to test the peroxidase activity, and that test is known as Guaic test. Anyways, what else? The non-specific features of malaise, cachexia, anorexia. So this is what is the classical symptom complex, and then we have a very important feature which is known as obstruction. Now, what is the classical presentation of gastric outlet obstruction? Let us try to understand. When we have a patient of gastric outlet obstruction, why this gastric outlet obstruction happens? Because of a mass. Simple, because of a mass. And because of this, what is the classical presentation? The patient will have what? Vomiting. So vomiting will be a classical early presentation of this, and because of the vomiting, there are a lot of changes which are going to happen. What are the classical changes which are going to happen, students? Because of vomiting, you will have a complaint of dehydration, point number 1. So there is dehydration. The second complaint that you are going to have is dyselectrolytemia. So electrolyte imbalance. So we have electrolyte imbalance, we have dehydration. What else? And what is important in this electrolyte imbalance? You get to see hypokalemia, hyponatremia, hypochloremia, lot of things. Do you know, if there is gastric outlet obstruction, there will be more and more loss of acid. So because of the loss of acid, what are you going to have? What is going to happen? So there is achlorhydria, and students, because of achlorhydria, what are you going to get? Yes, because of the loss of acid, metabolic alkalosis. So this achlorhydria will lead to a state which is known as metabolic alkalosis. Now the game will start. What is the game? Let us try to understand. Now you are having metabolic alkalosis. Now body will try its level best to buffer this alkalosis. And what will happen now? The body will give a command to kidney to lose the acid. So let us try to understand this. So when you talk about the case of gastric outlet obstruction. Now this is the kidney. This is the kidney. What you are expecting from the kidney? I am expecting from the kidney that the kidneys will lose the acid. Yeah, the kidneys should lose the acid. Why? We have a state of metabolic alkalosis. Yeah. So metabolic alkalosis, I am expecting the kidneys to lose the acid. But there is concomitant one more thing which is going on in the body, and that is the hyponatremia. The hyponatremia. Do you know the first priority of the kidney is to absorb any available sodium? So what happens if you see this to be the kidney and this to be the urine? Yeah, whatever sodium is present in the urine will be absorbed. So if this sodium is absorbed from urine to the kidney, so what is going to happen here? Yes, what is going to happen? Just try to see this. So if the sodium is absorbed, there will be deficiency of one positive cation. Yeah. So one positive charge is deficit, and you have to return that positive charge. So what are you going to return? Either you have to return the potassium. Already the potassium is deficit, so you are left with no option, and this hydrogen H plus has to go here, and the urine containing H plus, why H plus is exchanged? In order to maintain electrical neutrality. So why this has been done? This has been done to maintain electrical neutrality. So to maintain the electrical neutrality, a positive is exchanged for a positive, and this is what is going to result in acidic urine. So this is not understandable and explainable. Why? Because when you are having a state of alkalosis, your urine should be alkaline, but here you are getting aciduria. This is unlike the normal convention of what we are thinking, and anything which is not working in a proper convention, what is that known as? This state is known as the state of paradoxical aciduria. So paradoxical aciduria. What is the explanation of this paradoxical aciduria? That the sodium is absorbed because of its priority, and we give least priority to the metabolic status, and this is what is the explanation of paradoxical aciduria. Next, so we have discussed majority of the things. Now we have seen the risk factors. We will go to the staging. So I'll zoom the staging for you, but on the other hand, I will also write the staging for you. This is the staging. Let me move it a bit for you so that you can understand. Yeah. So this is the T part. Yeah. This is the T part of this. Okay. So when we talk about the staging, this is the staging that you are seeing in front of you. So T1, to be very honest, anywhere in the GIT, just a minute. Okay, just so anywhere in GIT, the T1 is further divided into T1A and T1B. T1A is equal to mucosa and T1B is equal to submucosa. To be it's very simple everywhere. T2, if you talk about T2, it is into the muscle or muscularis, into muscularis. T3, if you talk about, this is subserosal or perimuscular basically. So T3 is defined as subserosal. Then we have T4 anywhere in the GIT, the concept is same, that T4 is equal to invasion into the local structures. So T4 is local invasion. So let us talk about this local invasions. When we talk about the T4A means invasion into the serosa, and T4 invasion, that is the breach of serosa, and T4B is invasion into the local organs. When we talk about N1, we have N1 defined as, N1 is defined as 1 to 2 lymph nodes, N2 is defined as 3 to 6 lymph nodes, and N3 is defined as 7 or more lymph nodes. This is the most simplest version of staging that you can remember. So T1 is mucosa, submucosa, which is T1A and T1B. T2, T3. Why they are important? Just give me 2 minutes. I'll explain it to you. But what is the classical workup? Always remember, in GIT, the first line investigation has to be an upper GI endoscopy. So upper GI endoscopy and biopsy. This is the investigation of choice. Upper GI endoscopy and biopsy is the investigation of choice. Always remember, what is the utility of EUS? EUS may be used to estimate the depth of invasion of the tumor. Otherwise, we'll go for a CT abdomen, we'll go for a PET CT. Do you know that PET CT, unlike the different cancers, is not having a very strong indication in CA stomach? Do you know what is the reason? The answer is because the diffuse type, since it is diffuse, you know that what is the concept of PET? We give a radioactive food to the tumor and the tumor picks up that food and it glows. Yeah, it gives you a hot spot. But if you talk about diffuse type, the discrete distribution of the tumor cells will not have a significant uptake, and that is why we say that intestinal type of CA stomach is a PET evident, whereas diffuse type is not a PET evident. So, since majority of them are diffuse type, yes, we have to understand the role of PET CT. The role of PET CT is to evaluate the metastatic workup. So, whether there is a metastasis or no, and to evaluate the patient with and after the chemotherapy. So, NACT, you know, we give neoadjuvant chemotherapy to downgrade the tumor. So, we use the PET scan to re-evaluate how well they have responded. And the last is, we talk about the tumor markers. When we talk about the tumor markers, HER2 nowadays is a very important, and we are also even testing for MSI. We also are testing for MSI. So I'll go to the next, I'll go to the management part of this. I'll go to the management part. Just give me a minute. Let us see how to manage these tumors. So whenever we're talking about the treatment part, how to do? But we have diagnosed them to be adeno cancer. The next thing is we have to stage them. For staging, what are the things that we use? I've already told you, endoscopy for diagnosis. For extension of the tumor, we have CT, and we may go for EUS also. Now here we get to see a metastatic disease. If the tumor is metastatic, then we have to see whether the patient is asymptomatic. If patient is asymptomatic, then you will send the patient for palliative what therapy? Chemotherapy. If the tumor is causing obstruction despite the fact it is metastatic, suppose it is a growth which is associated with gastric outlet obstruction, so you will have to go for palliative resection and you will have to do a bypass, because the patient also needs to continue the GI tract. Here, if it is obstruction, you will have to go for. Now, if it is a metastatic disease, the first thing that we have to do is we have to reconfirm. And how do we do this? The staging laparoscopy. Do you know, nowadays we go for a diagnostic laparoscopy. Via this, like this, we make a 11 mm incision. Via this, we insert a telescope, see whether there is any serosal deposit, whether there is any peritoneal deposit, liver is free. If it is free, we go forward for the surgery. Now, I am going to discuss with you the concept of surgery for them. Try to understand. Suppose when we talk about the treatment, yeah? So okay. So let us see. Okay. So when we talk about the treatment of the patient, the treatment of CA stomach, students, the first thing that you have to understand is what T the patient belongs to. What T the patient belongs to. Suppose if it is T1 or if it is T2 and above. So if it is T2 and above, or any T with N positive. So any T with N positive. So do you know that gone are the days when we used to directly jump for the surgery if the patient is having a T2 and above status or any T is positive? The first thing that we'll go for is NACT. How many cycles? Into 3 cycles. What is this protocol known as? NACT, 3 cycles of NACT, then we'll go for surgery, and then we will go for post-operative chemotherapy. How many cycles? 3 cycles. A very famous trial. This is what is known as a magic trial. So this is very, very, very famous also. And this is what is known as a magic trial. So magic trial actually evaluated the response of the patients who underwent pre-operative NACT, after that surgery, and then again surgery, again chemotherapy, versus the patients who underwent surgery alone. It was seen that the disease-free survival was far better in this group. Next is, if you have a T1 tumor, that means it is involving what? Mucosa and submucosa. The next thing that you will have to ask is what T1 it is. Whether it is a T1A tumor or whether it is a T1B tumor. So if it is a T1A versus if it is a T1B. Students, if the tumor has gone to this T1B level, what does that mean? That means that the tumor has gotten access to the lymphatics. Submucosa has the lymphatics. The origin of lymphatics is at the level of submucosa. And that is why you don't consider them innocent and you straightforward go for what? Surgery. Is that clear or no? We'll see what surgery we do. Just give me 2 minutes. Now, if it is a T1A tumor, how to manage them? So, if it is a T1A tumor, how to manage? You ask yourself, less than 2 centimeter size. So, tumor size less than 2 centimeters, point number 1. And no lymphovascular invasion. So, no lymphovascular invasion and the tumor size less than 2 centimeters. If this is right, if this is true, so if the tumor size is less than 2 centimeters and no lymphovascular invasion is there, students, what are we going to go for? The answer is, if the answer is yes, then you are going to go for EMR. What do you mean by EMR? Endoscopic mucosal resection. You are going to go for endoscopic mucosal resection. If the answer to your question is no, that means that this tumor is more inclined towards what? A metastatic spread, lymphatic spread, and therefore these patients are to be managed with what? Surgery. So again, if the tumor, when we talk about the T staging, T1 and T2 and above, the protocol is different. T2 and above, we prefer to go for chemotherapy, and T1 tumors, we prefer to go for surgery. If it is less than 2 centimeter, T1A tumor, that means confined to the mucosa, size small, no lymphovascular invasion, will go for EMR. What is EMR, students? Endoscopic mucosal resection. Endoscopic mucosal resection. Is that clear to everyone? I hope that must be clear. The next thing is, what surgery are we planning to do and what lymphatic dissections are we planning to do? So when we talk about the surgery that we do, depends upon the location of the cancer. This depends upon the location of the cancer. If the location of the cancer is in the proximal stomach, so if it is either it could be the proximal stomach or it could be the body of the stomach, it could be the body of the stomach, or it could be the antrum of the stomach. So students, if it is involving the proximal stomach, then the treatment is total gastrectomy. So total gastrectomy. So I am using the word gastrectomy. Is that clear? Now, if the tumor is in the body, what to do now? We are going to go for subtotal gastrectomy. What do you mean by subtotal gastrectomy? More than 85% of the stomach is removed. More than 85% is removed. Now, when we talk about the tumor in the antrum, what is the management? Answer is either a distal or a partial gastrectomy. Let's say here also you can go for a partial gastrectomy. What is the partial gastrectomy? The partial gastrectomy is where you remove more than 65, and distal gastrectomy more than 30 to 35% of the stomach is removed. This is what is the treatment according to the location. The next very important thing that we all have to understand is, along with this, no surgery is completed until unless you do the lymph node dissection. So lymphatic dissection is again a very important part of this. So students, let us discuss the concept of lymphatic dissection. So gastric resection you have done. Now what is the lymphatic dissection? Let us talk about. So the concept of lymph node dissection. Students, if you talk about the lymph nodes, let us try to explain it to you. So there are certain lymph nodes in this area. There are certain lymph nodes in this area. So there are lymph nodes here. There are lymph nodes here. So these are the various stations of lymph nodes. MCH entrance also this year the questions have been asked. But so what are the stations of the lymph nodes that we have? This is station 1, this is station 2, this is station 3, this is station 4, this is station 5, this is station 6. Along with that, along the celiac trunk, you have certain stations. This is the left gastric. You have certain lymph nodes along this. This is 7. Along the common hepatic artery, you have certain lymph nodes which is known as 8. Celiac trunk, it's 9. And then we have the splenic. So this is spleen. So along the splenic artery, we have the lymph nodes. We have 10 and we have 11. So proximal splenic, distal splenic, these are the various group of lymph nodes that we have. And based upon these lymph nodes, you do the lymphatic dissection. Important is, what are the lymphatic dissections that we have? Students, strategically we have to remove these lymph nodes. We have something which is known as D1 lymph node dissection. What is a D1 lymph node dissection? What is a D2 lymph node dissection? Let us try to understand. D1, let us try to understand D2. So D1 versus D2 lymph node dissection. I'll go to next page, there I'll write. When you talk about the D1 versus D2, okay, let us try to understand this. Okay, just here. So removal of lymph nodes within 3 centimeter of stomach. So within 3 centimeter of the stomach, if you remove the lymph nodes, that is what is known as a D1 lymphadenectomy. So D1 lymphadenectomy. So that means, what do we mean by D1 lymphadenectomy, students? D1 lymphadenectomy means removal of 1, 3, 5 along the lesser curvature and 2, 4, 6 along the greater curvature. So 1, 3, 5 along the lesser curvature, 2, 4, 6 along the greater curvature. So 1, 3, 5 along the lesser curvature, 2, 4, 6 along the greater curvature. Next is, what is a D2 lymph node dissection? What is a D2 lymph node dissection? Let us try to understand. D2 is defined as D1 and along with that removal of lymph nodes along the lesser curvature, along the greater curvature Along with that, so you have 1, 3, 5, 2, 2, 4 and 6. Along with that, removal of lymph nodes. So along with that, you have removal of lymph nodes along the left gastric. So left gastric means you have to remove along the lymph node 7. Common hepatic artery, that means 8. Celiac trunk, that means the 9. And the splenic artery, that is 10, and we have 11. Students, this is D1 versus D2. There was a lot of argument which is better. D1 is better or D2 is better. Do you know, it was after the Dutch trial. The Dutch trial actually concluded that D2 is always better than D1. And before Dutch trial, we used to presume that D1 and D2 are all equivalent. We have D3 also, where you are in D3. What is a D3? What is a D3? D3 is not practiced in majority of the centers. So D3 is a D2, and along with that, you are going to remove the lymph node along the porta. So lymph node along the porta, along with that, along the outer. So para-aortic lymph nodes and hepatoduodenal. So here you are going to remove the hepatoduodenal. So hepatoduodenal lymph nodes, and here you are going to remove the para-aortic. So para-aortic and hepatoduodenal lymph nodes you are removing. Along with that, students, omentectomy. Along with that, the splenectomy. Along with that, you are also going to go for distal pancreatectomy. So, bache, don't you think plus minus distal pancreatectomy? So, don't you think this is going to add a lot of morbidity? And that is why D3 is not practiced in majority of the centers. So, this is what is the standard protocol of the management of the CA stomach. I'll show you a color palette. I've already told you that gastrectomy with the lymph node dissection is the most important. For proximal growth, total gastrectomy. For body and the mid gastric growth, subtotal. And for distal growth, distal or hemigastrectomy. D2 dissection is always preferred over the D1. Let us move forward and try to understand how we do the resection. Can you see? We have taken, along with the sample, we have taken a lot of mesenteric fat. Why this fat is important? Because this fat also contains the lymph nodes also. So what is this? This is the division of the distal stomach. This is the stomach, this is the pylorus, and this is the duodenum. So you are dividing, I have divided the stomach. This is the division of the proximal stomach with a green stapler cartilage. So I am dividing the stomach. This is how we do a gastrectomy. This is a case of partial gastrectomy. If you see, this is a lump. This is here the lump, where the lump is. And I have taken a sufficiently good margin of 5 centimeter. So we take a 5 centimeter margin. If you see, I have taken 3 or 4 fingers gap. Roughly one finger is equal to 1.5 centimeters. So here this is a sufficient gap. And after this, I have divided. So this is how we do a stomach resection. And after resection, you will have to go for reconstruction also. Suppose you have done this, so you will have to do a reconstruction. And what is the reconstruction that we all prefer? The roux and Y gastrojejunostomy, and here you have jejunojejunostomy. So if you see, I have made the rent in the jejunal loop, and now I will divide the jejunum. After division of the jejunum, I'm going to do the gastrojejunostomy. So here the gastrojejunostomy, this is the stomach, this is the jejunum. I have shown you this is a case of loop gastrojejunostomy. This is a loop gastrojejunostomy with jejunojejunostomy. This is a bronze procedure which is in front of you. What is a bronze procedure? Try to see this. इसको देखने की कोशिश करो. Just try to see this. These are all my own surgeries. कहीं से copy paste नहीं, so don't worry. This is stomach, this is the jejunum, and this is the gastrojejunostomy. And here if you see, this is a side-to-side jejunal-jejunostomy. So what is advantage of bronze? There is nothing known as efferent loop syndrome. Yeah, the biliary stasis is minimized in this case. So this is, again, I am going to show you a case of advanced CA stomach invading into the porta. So can you see, this is a classical rooftop chevron incision, and if you see, this is the stomach and this is the gallbladder, and there is loss of plane in between them. Can you see? This has invaded into, so it's an advanced case, and for this I have decided, can you see, this is the lymph node this is metastasized, this has metastasized into the mesentery. So there is a mesenteric puckering here. This is the mesenteric puckering. I have taken out the sample. Later on it turned out to be a adenocarcinoma. So it's a metastasis to mesentery, hence this case is irresectable. So after that, what have I done? I have decided to go for the bypass. So this is the lymph. I have already told this protocol. If the patient is symptomatic, this patient was having gastric outlet obstruction, so I had to do something. So I have done a gastro-jejunostomy. So this is a loop gastro-jejunostomy for you. Loop gastro-jejunostomy. Can you see? This is the enterotomy and this is the gastrostomy. So if you see here, this is enterotomy. This is enterotomy and this is gastrotomy. So this is enterotomy versus gastrotomy. If you see, this is the after taking the corners, the corners we take with the corners. Let me change the color. Okay, so after taking the corners, I have taken the posterior layer. So this is a posterior layer, and then now this is the anterior layer. So anterior layer and the posterior layer is in front of you, and then finally it is completed. This is a specimen of CA stomach. So finally this surgery has been done, and I have explained you the concept of management. I hope you enjoyed this session, and do follow me on Unacademy, and if you enjoyed this, do join me on the Plus platform. Use Dr. Dixit to unlock the app for the free special classes. Do join the Plus program. Do give your feedbacks about the class. Do share the links share the links to your friends, and do recommend Unacademy to your friends. I hope you enjoyed a lot. Let me see if you have a query. How do you do? Shamshuddin has asked, how do you decide whether the patient gets a D1 versus D2? Shamshuddin, this depends upon the surgical expertise of the consultant. At least D1 has to be done. If you are a confident surgeon, if you know how to bear the lymph nodes near the big vessels, you can go for a D2. But at least D1 should be done. It has been said that D2 is always going to have a better prognosis. So I hope, Shamshuddin, your query has been solved. Any more queries? Yeah. So I hope you enjoyed this session. I actually enjoyed a lot with you people. So do give your feedbacks about the class. Do recommend Unacademy to your friends.